Hi students, hope you are doing well. Our topic today is basal ganglia and cerebellum. Please enjoy. The learning objectives are: describe the function of basal ganglia. Explain the role of neurotransmitters in basal ganglia disorders. Describe the functions of cerebellum. Explain the consequences of abnormalities of cerebellar functions.
Welcome to 2-Minute Neuroscience, where I simplistically explain neuroscience topics in 2 minutes or less. In this installment, I will discuss the basal ganglia. The basal ganglia are a group of structures found deep within the cerebral hemispheres in the brainstem that include the caudate, putamen, globus pallidus, substantia nigra, and subthalamic nucleus. The caudate and putamen are often referred to collectively as a striatum, and the globus pallidus and substantia nigra are each made up of multiple nuclei. Although there are a variety of non-motor functions associated with the basal ganglia, they are best known for their role in facilitating movement. Much of the information the basal ganglia receives comes from the cerebral cortex and travels first to the caudate or putamen, the main input nuclei of the basal ganglia. The globus pallidus and substantia nigra are the main output nuclei, and they send projections out from the basal ganglia to the cerebral cortex, mostly by way of the thalamus, as well as to nuclei in the brainstem. Activity in the nuclei of the basal ganglia doesn't cause movement independently, but instead the basal ganglia influence activity in other areas of the brain, like the motor cortex, to affect movement. The ways in which the basal ganglia do this are not fully understood, but one hypothesis is that there are different circuits in the basal ganglia that promote and inhibit movement respectively. According to this model, the main output of the basal ganglia is inhibitory, and neurons in the globus pallidus are constantly inhibiting the thalamus to prevent unwanted movements. When a signal to initiate movement is sent from the cortex to the basal ganglia, it follows a circuit in the basal ganglia known as the direct pathway, which leads to the silencing of neurons in the globus pallidus. This frees the thalamus from the inhibitory effects of the globus pallidus and allows movement to occur. There is also a circuit within the basal ganglia called the indirect pathway, which involves the subthalamic nucleus and leads to increased suppression of unwanted movements. It is thought that a balance between activity in these two pathways may allow for smooth movement.
As introduction, basal ganglia are cluster, bunch of deep nuclei located at the base of forebrain. They primarily involved in control of posture and movement. They also do not directly project to the brainstem areas that control motor activities. They receive inputs mainly from cortex and project to the cortex via thalamus. Lesion of basal ganglia produces abnormal movements and severe deficits in control of posture. From anatomical structure, basal ganglia mainly include caudate nucleus, the putamen and the globus pallidus. Subthalamic nucleus and substantia nigra are also included in basal ganglia. All these structures, including the thalamus, are working together to control our movement. The way they communicate each other is through these pathways, where neurons talking to each other using chemicals, called neurotransmitter. Glutamate is excitatory neurotransmitter, turns activity up, excitation of the movement. GABA is inhibitory neurotransmitter, turn it off, inhibition of the movement. Direct pathway is to excite movement and indirect pathway is to inhibit the movement, so that we can hold and move the cup without spilling the water, and making sure our muscles are not moving when we're at rest. Input to basal ganglia. Basal ganglia do not receive direct sensory input from the peripheral structures, spinal cord or sensory nuclei in the brainstem. The main inputs to basal ganglia come from cerebral cortex. Basal ganglia also receive inputs from thalamus, dorsal raphe nucleus and pedunculopontine region of the brainstem. Output of basal ganglia. The principal output nucleus of basal ganglia is the internal segment of globus pallidus. The fibers project mainly to the ventral lateral, ventral anterior, and centromedian nuclei of thalamus, from where fibers project to prefrontal and premotor cortices. The output from the internal segment of the globus pallidus to the thalamus is inhibitory, whereas the output from the thalamus to the cerebral cortex is excitatory. Functions of basal ganglia. The neurons of basal ganglia are observed to discharge before the movement begins. This indicates that basal ganglia is involved in planning and programming of motor activities. Basal ganglia controls posture. Basal ganglia thalamic cortical projection to brainstem influences descending pathways that control posture. Diseases of basal ganglia result in profound postural abnormalities. Basal ganglia inhibits stretch reflexes by stimulation of caudate nucleus. This is achieved by stimulation of inhibitory motor cortex through thalamocortical feedback pathway and by stimulation of inhibitory reticular formation. Basal ganglia also play a role in cognitive functions. This is especially performed by the caudate nucleus through its connections with the frontal portion of the neocortex. Lesion of caudate nucleus results in deficit in performance based on learning. Helps in articulation. Globus pallidus provides inputs for appropriate muscle tone for skilled movements. Substantia nigra is the center for coordination of impulses essential for skilled movements. Basal ganglia controls associated movements that occur automatically and normally with various body movements. For example, emotional expression. Control how much large and how rapidly the movement should be done. Neural pathway through basal ganglia. To make movement, there are two types of neural pathways involved, which are direct pathway and indirect pathway. Which is, direct pathway allow us in making the movement or holding a cup of water, while indirect pathway prevent us from making unwanted movement. For example, avoid from spilling of water. Both pathways work all together in a smooth streamline. Watching this video, then you can get this keyword for direct and indirect basal ganglia pathways.
In this video, I'm going to be talking about the basal ganglia pathways, specifically the difference between the direct and the indirect pathway. Now let's get into today's video. Again, it's on the basal ganglia, and specifically we're going to be differentiating the two pathways, the direct pathway and the indirect pathway. And this is a really challenging topic for a lot of medical students because each of these two pathways has a lot of distinct parts to it, and you need to know certain things in each pathway. So what's the anatomical structure in the brain? Is the pathway subcomponent excitatory or inhibitory, etc., etc. And before we get into those nitty-gritty details that you absolutely need to know, I think we should just begin with a little bit of an overview about what the basal ganglia is. So the basal ganglia is actually a collection of interconnected structures. Like, you don't look at the brain and say, oh, that's the basal ganglia. Really, it's a group of subcortical interconnected structures. And neuroanatomy is really complex for a lot of medical students because people just don't take the time to look at the words and understand the terminology being used here. But when something is subcortical, it means below the cortex. So if you look at the brain, the outer kind of peripheral part of the brain, the meat, if you will, that's all cortical. That's all cortex, right? Frontal cortex, parietal cortex, temporal cortex, etc. So anything deep to that is subcortical, and that's what we're talking about with the structures that comprise the basal ganglia. Now, specifically, those structures include the caudate, the putamen, which together, the caudate and the putamen are the striatum, the globus pallidus, which has two subcomponents, the globus pallidus internus and the globus pallidus externus, the subthalamic nucleus, and the substantia nigra. Okay, so all of these parts together make up the basal ganglia. So these are all subcortical neuroanatomical parts of the brain that together comprise the basal ganglia. Now, the overall effect of the basal ganglia is to coordinate movement. And it uses both excitatory and inhibitory interneurons to connect these structures. And as a general rule of thumb, any neuron that uses glutamate is going to be excitatory, and any neuron that uses GABA is going to be inhibitory. This is a really big, high-yield concept for you to understand, not only for USMLE and COMLEX, but moving forward in your medical career. Glutamate, excitation; GABA, inhibition. Just memorize it, and that's really what you need to know. So when I reference the interneurons in these pathways, in this video specifically, if it's a glutamate neuron, it will be shown in green, which means it's exciting, it's excitatory. And if it's a GABA interneuron, it will be shown in red, which means it's inhibiting because it's inhibitory. Now, the basal ganglia has two distinct pathways. There's the direct pathway and the indirect pathway. Each of these two pathways has two distinct goals. The direct pathway initiates movement, and the indirect pathway terminates movement, okay? And this will become a little bit more clear once we go through the pathway and I illustrate what's going on. Now let's get started with the pathway. So you start with the motor cortex. So the motor cortex sends excitatory signals to the striatum. Now remember, the striatum is the caudate nucleus plus the putamen, okay? But for the purposes of simplifying on the slide and in the video to help you memorize this, I'm just going to write striatum. So motor cortex sends excitatory neurons, which again are glutamate, shown in green, to the striatum. And then the striatum sends inhibitory neurons, which are GABA, shown in red, to the globus pallidus internus and the substantia nigra. The substantia nigra and the globus pallidus internus send inhibitory neurons to the thalamus, and the thalamus sends excitatory neurons back to the motor cortex. Now this loop, everything you see here, this is the direct pathway. And the net effect, again, of the direct pathway is to turn on the motor cortex. And really what's happening here is you're disinhibiting thalamic control of motor planning. So again, the basal ganglia's role is the coordination of movement. It coordinates movement. It plans motor movement. It's as if you're assigning purpose to the movement of the body. Now, in order for the brain to do this, the thalamus, which is the sensory integration center of the brain, has to communicate with the motor cortex of the brain, because the motor cortex is what's responsible for taking different signals and yielding motor output. And it's through this loop that the direct pathway initiates movement. Okay, so everything that you see on this slide is direct pathway. Now let's pivot for a second and talk about the indirect pathway, and then we'll come back and we'll compare and point out all the high yields that you should remember. So the indirect pathway starts with the motor cortex at the top of the slide, and just like the direct pathway, it too starts with sending excitatory signals to the striatum. And this is where the pathways differ. So the indirect pathway, the striatum then sends inhibitory interneurons to the globus pallidus externus. So you can see in the flow chart, if you will, that we've now pivoted into the indirect pathway. The globus pallidus externus will send inhibitory interneurons to the subthalamic nucleus. And then the subthalamic nucleus will send excitatory interneurons back to the globus pallidus internus and the substantia nigra. And at this point, the indirect pathway kind of takes a turn and comes back and finishes out the exact same way as the direct pathway, which is to say that the globus pallidus internus and the substantia nigra send inhibitory signals to the thalamus, and then the thalamus sends excitatory signals to the motor cortex. So the left side of this flowchart is direct pathway, which we already talked about, and the right side of this pathway is the indirect pathway. And the net effect of the indirect pathway is to turn off the motor cortex. Okay, so you're activating the inhibition pathway, if you will. Now, this can be a little confusing for some people, so I really want you to hone in on what the two differences are clinically and functionally in these pathways. And really what you need to understand and look at is the substantia nigra. The substantia nigra's role chiefly is to inhibit movement. So normally the substantia nigra inhibits the thalamus, which would normally excite the motor cortex. So if you're inhibiting the thalamus, and therefore the thalamus cannot excite the motor cortex, you don't get planned movement. In the direct pathway, what you'll notice is that the striatum turns off the substantia nigra, which is where you see the pink plus sign next to the red arrow going from the striatum down to the substantia nigra. This in the direct pathway is disinhibition, right? Because you're inhibiting the thing, the substantia nigra, that normally inhibits motor planning. So in the direct pathway, it would be correct to say that the direct pathway disinhibits thalamic control of motor planning because you're turning off the thing that causes inhibition. Okay, you're turning off the substantia nigra, which normally causes inhibition. Now compare that to the indirect pathway. In the indirect pathway, the subthalamic nucleus is sending excitatory neurons to the substantia nigra. So it's turning on the substantia nigra, which means it's turning on the thing that causes inhibition. Okay, so when you turn on something that inhibits, the overall effect is inhibitory. But when you turn off something that inhibits, as is the case in the direct pathway, the overall effect is excitatory. So as you can see, the reason that the direct pathway causes activation of motor planning and the reason that the indirect pathway causes inhibition of motor planning is totally dependent on whether you're turning on or turning off the substantia nigra. So the really key nuance in these pathways happens right here where those pink plus signs are. What happens to the substantia nigra? And this is what you really need to understand on a deep level, especially in the first 2 years of medical school when you're taking your exams, but also for USMLE and COMLEX. So those are the differences, and I know what you're thinking. You're saying to yourself, wow, dirty. How the heck am I going to remember the order of these structures and what's going on? And the answer is pretty simple. You're going to use my awesome mnemonic. So here's what you do. You write MCIT, right? MCIT. M for motor cortex, S for striatum, I for internus, right? Globus pallidus internus, and T for thalamus. Okay? That's what you write for both direct and indirect. And there's one difference between these. In the indirect pathway, you add in the middle. Okay, so it's still MCIT, but in the very middle, smack middle between the S and the I, you add in because the indirect pathway adds in. And this reminds you that in the indirect pathway, you're also adding the externus, right? Globus pallidus externus, and the nucleus or the subthalamic nucleus. So if you remember MCIT for direct and indirect and add the in for the indirect pathway, you'll always be able to remember what the order of these structures are. Again, just to hammer this home, motor cortex, striatum, globus pallidus, internus, and thalamus. And then in the indirect pathway, you add in, which is globus pallidus externus, and the nucleus or the subthalamic nucleus. So write this out on a piece of paper a couple times so that your brain remembers what this looks like. But MCIT, MCIT, and then add in for the indirect pathway. And this is how you're going to remember the order of these pathways. So here we go. We've got MCIT for direct and MCIT with in for the indirect pathway. And now you need to know which one sends excitatory signals, which one sends inhibitory signals. Because remember, half of the battle in memorizing this pathway is understanding if there's glutamate involved and it's an excitatory signal, or if there's GABA involved and it's an inhibitory signal. And the way that you do this is it's pretty simple. The first and last part of the pathway is excitatory. The part in the middle is inhibitory. And it's the same between the direct pathway and the indirect pathway. So you see direct on the left, and now look at indirect on the right. So the M, the S, the I, and the T, it's the same, right? First and last is excitatory. The two middle parts, the S and the I, are inhibitory. The only difference now is the in indirect pathway. And in indirect pathway, just memorize that the first part, the E, that's inhibitory, and the second part, the N, that's excitatory. So what should you memorize? Like, what's the mnemonic here? Remember that first and last are excitatory. Everything in the middle is inhibitory, except for the subthalamic nucleus, right? The subthalamic nucleus will be excitatory. So this is what I used to remember back in the day when I was a medical student, and this is very sufficient to answer all of these questions correctly. But that's it for today's video. I hope that this was helpful for you. The basal ganglia pathways are very, very important, very high yield, and quite frankly, it's impressive if you're able to talk about this stuff as if you know what's going on.
Basal ganglia disorders. There are several basal ganglia disorders like Parkinson's disease. Parkinson's disease resulted from degeneration of nigrostriatal dopaminergic neurons. With age, There is progressive loss of dopamine and dopamine receptors in the basal ganglia. When this process is accentuated, Parkinsonism results. Few causes of Parkinson disease. First, idiopathic. The cause of degeneration of dopaminergic neurons is not exactly known. Second, drugs. It occurs secondary to chronic use of many drugs like phenothiazine and D2 receptor blockers. Third, MPP. It has been recently described that methylphenylpyridinium, MPP, concentration in the brain of Parkinsonism is high. MPP is formed from methylphenyl tertihydropyridinum, MPTP, by the action of monoamine oxidase B, MAO-B, enzyme. MPP rapidly accumulates in the neurons of basal ganglia and destroys them. Features of Parkinson's disease. Both hypokinetic and hyperkinetic movements are observed in Parkinsonism. Hypokinetic movements. Akinesia. Akinesia is defined as difficulty in initiating movements and decreased spontaneous movements. Bradykinesia. Bradykinesia is defined as slowness of movement. Decreased associated movements. Examples of associated movements are swinging of the arms during walking or the facial expressions during speaking. These associated movements are grossly diminished in Parkinsonism. The patient suffering from Parkinsonism speaks without any emotional expression, expressionless face or mask face. Hyperkinetic movements. Tremor. Tremor occurs due to regular alternating contractions of antagonist muscles, at a frequency of about 8 per second. Typically, tremor is observed only at rest. Once patient initiates the movement, tremor disappears. This is described as resting tremor. Festinant gait. Patient walks in an attitude that as if he is trying to catch the center of gravity. Usually, he bends forward but does not fall, instead takes short and shuffling steps. Several treatment provided for Parkinson such as replacement of dopamine. Dopamine cannot cross the blood-brain barrier. Therefore, L-DOPA, a precursor of dopamine that easily crosses blood-brain barrier, is the drug of choice for Parkinsonism. It also helps repair dopamine deficiency. Other dopamine agonists like bromocriptine are also used. Anticholinergics. Though Parkinson's disease occurs due to dopamine deficiency in the striatum, the alteration in the ratio of dopamine to acetylcholine plays an important role. Therefore, injection of anticholinergics that decreases acetylcholine concentration in the basal ganglia and reestablishes acetylcholine-dopamine ratio. Improves the symptoms. Deprenyl. Deprenyl inhibits monoamine oxidase B. Therefore, prevents formation of MPP from MPTP. Transplantation of adrenal. Transplantation of adrenal medulla from one of the adrenal gland of the patient into his basal ganglia helps in regenerating the dopaminergic neurons. Implantation of fetal basal ganglia. Implantation of tissue from the basal ganglia of fetuses into the basal ganglia of the patient improves the condition. Transplantation of glomus cells. Recently, for treatment of Parkinsonism, glomus cells from carotid body are isolated and transplanted into basal ganglia. GLO-Muse cell releases dopamine locally. This has been found to be encouraging. As a summary, treatment for Parkinson involves replacement of dopamine, using of anticholinergics, deprenyl, transplantation of adrenal, implantation of fetal basal ganglia and transplantation of glomus cells. Huntington's disease. This is a genetic defect of autosomal dominant type that occurs due to a defective gene on the chromosome 4. The gene codes for Huntington, an abnormal protein that causes the disease. The disease occurs due to degeneration of GABAergic striatonigral pathway. GABAergic and cholinergic neurons are lost in the striatum. Features. Age. Disease usually starts between the age of 30 to 40 and progresses uniformly till death occurs within 10 to 15 years. Disease has three important features: chorea, dementia, and slurred speech. Chorea. Chorea is defined as rapid involuntary and dancing movements. The chorea is called Huntington's chorea. It is believed that loss of GABAergic neurons in the striatum removes its inhibitory influence on the globus pallidus, which reduces the activities in the thalamic nucleus that results in chorea. Dementia. Dementia occurs due to simultaneous and progressive loss of cholinergic neurons in the cerebral cortex. Slurring speech. Gradually, speech is slurred in Huntington's disease. There is no definite treatment of Huntington's chorea. The disease is progressively fatal. Ballism. Ballism is defined as involuntary movements that are flailing, intense, and violent in nature. Usually, it occurs suddenly. Ballism occurs when the subthalamic nucleus is damaged. Hemiballism is common than ballism and occurs due to hemorrhage in the subthalamic nucleus of the opposite side of the brain. Athetosis. Athetosis is defined as continuous but slow writhing movements. It occurs due to damage to striatum. Chorea. Chorea is defined as rapid involuntary dancing movements. It occurs due to damage to caudate nucleus. For functions of cerebellum, please enjoy this video.
What do you guys think? Can my ability to spin the ball around the racket, particularly without looking, showcase all the major functions of the cerebellum? Let's find out. Alright guys, welcome to Psych Explained. In this video, we're going to dive into the cerebellum. Now, one of the reasons I really enjoy talking about this structure is because it's impossible to imagine life without it. From driving a car, to riding a bike, to going for a jog, to playing a musical instrument. The cerebellum is at the root of all that. All right, let's get started. Now, in this video, we're going to focus on three primary functions of the cerebellum. But first, let's start in this structure here. Let's understand where the cerebellum is located and also its surrounding parts. Now, a nice way to think about the brain is that it's divided into three major parts. One of those is being the cerebellum. Now, the largest part of the brain, this giant mass here, is what we call the cerebrum. All right, this whole structure, and we can label it over here. Okay, so here's the cerebrum. Now, what do we know about the cerebrum? We know that's divided into two hemispheres. We have our left hemisphere and our right hemisphere. We also know that the top of the cerebrum is covered by a thin layer of gray matter called the cerebral cortex. Right? When you close your eyes and you envision the brain, it's got a lot of wrinkles and folds. That's the cortex of the brain. And we can kind of draw that cortex to showcase those folds and those wrinkles, and that sits on top of the cerebrum. Now, what does the cortex do? Well, the cerebral cortex is responsible for higher functions, things like learning and organizing and decision-making and problem-solving, and even things like speech and processing vision. You could also think about the cortex that is divided into four lobes, and it's always important to practice those lobes, so do it with me. We have our frontal lobe, we have our temporal lobes, we have our parietal lobes, and we have our occipital lobe, which sits in the back of the head. All right, so there's our cerebrum. That's our largest structure. Our second structure is located right below the cerebrum. I like to call this the survival structure. It is also the oldest structure here in green, and we call this the brainstem. The brainstem. Now, why do I call it the survival structure? Well, quite simply, the things that we need to survive are located within the brainstem, like breathing and heart rate. Or if you've ever choked on food and you have that reflex to cough to get the food out, you could thank your brainstem for that. Now, another way to think about the brainstem is kind of this connector. And what I mean by that is that it connects the cerebrum, the top of the brain, to the lower body, right? So everything that flows or ascends up to the cerebrum or goes down or descends has to flow through the brainstem. So we have a lot of information that goes through there, all right? So we have the cerebrum and we have the brainstem. Now, directly behind the brainstem, right in the back of the head, and underneath the cerebrum, more specifically the occipital lobe, is our main structure for today, and that is in red. And this is the cerebellum. Let's make sure we write that there. Cerebellum. Now the cerebellum comes from the word meaning little brain. Now why is it called little brain? Because of its striking resemblance to the cortex of the brain, right? In other words, in this picture it looks very smooth, right? There's nothing there, but it's actually got a cortex. It's got a lot of folds and wrinkles similar to the cerebral cortex that sits on the cerebrum. It is packed with neurons, right? I would say a general rule of thumb. If you're a teacher or you're reading in a textbook and they say a part of the brain is packed with neurons, you know that plays a vital role in everything we do. All right, so here's our cerebellum. So we have the cerebrum, we have our brainstem, and our cerebellum, our three main parts. Now a nice way to think about the cerebellum as well, and I'll draw an arrow to this structure right here. You know, I feel like a lot of times we look at the brain, it always looks like this. That doesn't really do justice. I think whenever you look at the brain, you should always look at it from multiple angles. So what do you notice here? Like what differences do you notice between this figure and this figure? Well, it shows us is that we have two cerebellum, right? We have two hemispheres, our left hemisphere and our right hemisphere, which sense we have a cerebellum on our left and our cerebellum on our right. So this person would be facing this way, and this would be the back of the head, all right? We'll also talk about why it's important to know this, because as information flows up through the brain or descends down, it's gonna go to different hemispheres, and we'll dive into that in a moment. All right, so there we go. We have our three main structures. We have looking at the cerebellum from multiple angles, and actually we can add the folds here as well, right? So we know we have our right cerebellar cortex and our left cerebellar cortex, so we can visualize that as well, all right? All right, let's dive into the major functions. All right, the first function of the brainstem, of the cerebellum, is what we're going to say is balance and posture. Okay, balance and posture is the first major function. Now, what do we mean by balance? Well, my ability to stand up without falling over, right? I have a good sense of equilibrium. I'm able to walk straight, right, in a nice straight line. If you have cerebellar damage, it's very hard to walk in a straight line, okay? So this is what we mean by balance, right? If you do yoga, you do sports, and you're kind of moving your body, that is all balance. Now, how does the cerebellum play a role in balance? Well, here's what I want you to think about. There are three primary systems, and the cerebellum is influenced or communicates with all three systems. We're going to go over them, and at the end, I want you to remember and talk back to me, what are those three systems? Okay, so I want you to remember that we have three of them. Okay, here's the first one. Well, let's say, for example, you want to lift your leg in the air. Okay, so I have a nice lift, and I have to have nice balance. Well, how does that reach the cerebellum? Well, we have receptors all over our body. We have receptors right underneath my skin that pick up things like temperature, hot and cold, or pain or vibrations. We also have sensory receptors within the skin attached to my muscles, my ligaments, my muscles, and my joints. And what we call these, I'll have my little dots here, we call these proprioceptors, okay, proprioceptors. Now, proprioception is essentially our awareness in space, right? I know where my legs are, I know where my limbs are. This is proprioception. All right, and we can write this here, proprioceptors. Okay, so here's the first one, receptors. So what happens? Well, as my leg lifts in the air, this information has to reach the cerebrum. And that information is going to go up from my muscles, from my ligaments, from my limbs, all the way to our central nervous system. And we'll have an arrow so we know that this is going up, okay? So where does it go from there? Well, this is going to go up or ascend to the brainstem, and once it reaches the brainstem, it's going to synapse with another neuron, okay? So it's going to synapse with another neuron, and that information is going to continue to flow to the cerebrum. Now, there are two main parts this is going to flow to. It's going to go to the sensory cortex, okay? This is the part of the brain that registers and integrates sensory information, right? Hot and cold and temperature, pain and vibrations, everything goes there. So this is going to flow through the thalamus. Okay, all of our senses go through the thalamus except for smell, and then it'll eventually synapse with the sensory cortex. Okay, so this lets you know that your leg's in the air. What's also going to happen is this message is going to flow and communicate and synapse with your cerebellum as well. So that's make sure that we have our legs in the air and we're nice and balanced. All right, so there's our proprioception. That is our first part of balance. All right, what's our second part? Well, have you ever tried to stand still with your eyes closed with your leg in the air? I want you to try it at home, okay? Put your leg in the air, which you probably can't see, and close your eyes. It's really hard to do, okay? And that is why our second system, our visual system, plays a key role in balance. So our eye would be around here, and we'll use a different marker. And essentially, our eye is going to take information and send it out to different areas of the brain. Okay? One of those, of course, being the cerebellum. So the cerebellum is going to pick up information from our visual system as well. All right, so we have our proprioceptors, we have our visual system. So what's our third system? What's the third system that helps with balance? It's our ear. Specifically, our inner ear, or what's called the vestibular system, okay? So as I turn my head and do this with my head, my ear is signaling my brain where my head is in space, and that's going to help with balance as well. So there's our three. We have proprioceptors, we have our visual system, and we have our vestibular system. Now this angle over here, this diagram, this is also really nice to look at these three systems, right? This kind of, it's easy to see here, but it's better to see when you have two hemispheres, okay? So here's our example. We have our inner ear, and let's say our inner ear is on the right side. This is our vestibular system. Where's this information going to go? Well, the information is going to flow to the spinal cord, right, through the brainstem, and that's going to ascend, go up to the brain. Now remember, everything's crisscrossed. What do I mean by that? Well, if it's from the right ear, this information is going to flow to the left hemisphere, right, the auditory cortex of the left hemisphere, the auditory cortex of the left hemisphere, right? Everything is crisscrossed. Or let's say my left leg is raised. Okay, so here's my left leg. Okay, those proprioceptors are going to go up my spinal cord through my brainstem, right? They'll synapse with another neuron. Now, where do you think it's going to go? If the information is from my left leg, where's the information going to go? It's going to go to my right hemisphere, right? And it's going to go to what part? My sensory cortex of my right hemisphere, my sensory cortex. Oh. And of course, this will communicate with our, cerebellum as well, okay? So that's a really nice way to think about it, right? I always say this, don't just look at the brain from one angle, look at it from multiple angles. That will really help you, okay? All right, so there's number one. We have balance, and our cerebellum plays a vital role. All right, our second main function, and we're going to write this, is called coordinated movement. Okay, make sure I got there. There we go, coordinated movement. All right, let's break this apart to make sense of what I mean by this. Let's start with movement. Now, when I talk about movement, I mean voluntary movement, right? I choose to lift my arms when I'm lifting weights. I choose to move my head, right? I choose to lift my leg. This is what we call voluntary movement. Involuntary would be something like blinking. You don't think about it, it just happens. We also have coordinated, right? This means that things are in sync with each other, right? I can touch my nose when I choose to. I could do it at the same time. This is coordinated. Or I could have my finger out here and move it and touch it as it moves. This is coordination. Okay, so how does this play a role in the cerebellum, or how does the cerebellum help with coordinated movement? Well, let's start up here, okay? When your muscles move, it has to start from what we call the motor cortex, and that's what I have up here in purple, and this is located in our, can you think about what lobe? It is our frontal lobe, okay? So this is in our frontal lobe, our sensory cortex is in our parietal lobe. Okay, so we have our primary motor cortex. And this is going to send information through the body to move our muscles. So we go through our thalamus, as we all do. Okay, everything goes through the thalamus, and then that is going to continue down. Now here's what happens. As that information flows down to our muscles, it is also going to make a pit stop, so to speak, at our cerebellum. Okay? In other words, as the information flows down, your motor cortex is communicating with your cerebellum, telling the cerebellum what it's doing. It's almost like this, back and forth conversation. Hey, cerebellum, I just want to let you know I'm going to go put the leg down. Are you okay with that? Right? The cerebellum will talk back. Yes, you can do it. I just got to make sure there are no errors and everything is coordinated, right? So you kind of got this back and forth communication going. So this information is going to continue to descend, flow down. It will synapse with another neuron and go down to our leg. It will make sure we have arrow going this way so you know it's going down. And I'll go to the leg, right? And that might, maybe I'm putting my foot down there, okay? So that's a nice way to think about coordinated movement. It's not just your motor cortex. It's got to communicate with the cerebellum and let the cerebellum know what's happening so there are no errors and everything is fluid. And then your cerebellum will communicate back to the motor cortex saying, everything is okay, you can do it now, I agree, okay? So there we go, we have coordinated movement. All right, what is our third function? Well, our third function is what we call motor learning. Now, what do I mean by motor learning? Motor learning, you want to think about muscle memory, right? This essentially is doing a task without much effort. For my musicians and my athletes, you know about this, right? Whenever you start a skill, it's really hard, it's really taxing, right? Dribbling a basketball, playing guitar, playing piano, you have to think about it, right? But the more you do it, it becomes more fluid, right? Essentially, it becomes just this repetitive motion and you don't even have to think about it, right? How many of you can text on your phone without looking, right? That's motor learning. And your cerebellum plays a vital role in that. Now, another way to think about this, kind of a subcategory, is what we call implicit memories. Implicit memories, right? In other words, whenever I think about memories and I talk to my students, they always go, oh, the hippocampus, the hippocampus. Well, not necessarily. Not all memories are created equal. Yes, your hippocampus plays a role in forming new memories, explicit memories, but when it comes to memories you don't really think about, driving a car, riding a bike, your cerebellum plays a bigger role. All right, so that's a nice way to think about it. So, nice summary, we have balance, we have coordinated movement, and we have motor learning. Those are our three functions. Now, I asked you at the beginning, let me get my tennis racket out, my little tennis ball. How can this motion, let's do it together, how can the cerebellum be used to explain how I can do this with my rackets? Okay, let's think about it. First, we have balance, okay? So I'm able to balance the ball, right? I have nice equilibrium. I'm moving, right? But the ball's not falling over. We have proprioceptors in my muscles, sending information to my brain and communicating with my cerebellum as well. So I know where everything is, right? My sensory cortex helps me feel the racket. There we go. Other things, we have vision, right? I'm looking at it. Okay, I'm looking at it. And also my inner ear, right? I can turn my head and my brain knows. All right, coordinated movements. Okay, well, I have my motor cortex sending information down my brain, down my arm, allowing me to move my muscles. Okay, this is my motor cortex. And to make sure that I don't go too fast or too slow and I have no errors, that's where my cerebellum comes in. So it's not just my motor cortex controlling my muscles, my cerebellum makes sure that my wrists don't go too far, right? And the ball falls off. And lastly, motor learning. If you've ever tried something for the first time, you know how hard it is. Now, I played tennis for quite a while, okay? And I'll do this with some of my players that I coach. And it's hard at first, right? It's something that you have to really think about and you make a lot of errors. But over time, right, I can look at you and I can still do this because essentially it's muscle memory, right? I'm not really thinking about it. It just kind of happens, all right? So there is our three. All right, guys, thanks for watching. I really hope you took something away. Don't forget to like the video, comment below, and also subscribe. Until next time.
Please bear in mind about the function subdivision of cerebellum. Spinocerebellum. To smoothen and coordinate the movement. This is the function of spinocerebellum that receives proprioceptive and other sensory inputs from all the body parts through the spinal cord. It also receives inputs from the motor cortex, where motor planning is carried out. By comparing plan with performance, it smoothens and coordinates movement. Spinocerebellum regulates the postural reflexes by modifying muscle tone. Cerebellum influences the activity of the major descending medial system pathways through its output from fastigial nucleus, especially the vestibulospinal and reticulospinal tracts. Control of skilled voluntary movements. Cerebellum is not able to initiate movement but coordinate movements initiated by motor cortex. Control of movements by cerebellum includes regulation of time, rate, range, extent, force and direction of muscular activity. Cerebrocerebellum, for planning and programming of the movements. This is the function of neocerebellum that interacts with the cortex. Hence, neocerebellum controls planning and programming of the movements. For learning and improvement of motor skill, cerebellum plays a critical role of comparing information of the ongoing movements and the changes required to improve performance. Vestibulocerebellum, which involves with control of postural balance and equilibrium. This is the function of vestibulocerebellum, which has extensive and reciprocal connection with the vestibular nuclei. Vestibular functions involves in control of all vestibular functions, such as balance during movement, execution of vestibulo-ocular reflex, vestibular postural reflexes and change in body posture and movement in response to head movement and acceleration. Vestibulocerebellum, vestibulo-ocular reflex. Vestibulocerebellum is concerned with learning-induced changes in vestibulo-ocular reflex, head motion or visual target motion. Eyeball movement. The paraflocculus and pyramis of cerebellum are concerned with movement of eyeball and gaze holding. The cerebellum plays a pivotal role in the control of eye movements. Its core function is to optimize ocular motor performance so that images of objects of interest are promptly brought to the fovea where visual acuity is best and kept quietly there, so the brain has time to analyze and interpret the visual scene. Cerebellar disorders. In general, cerebellar disorders have the following features. First, no paralysis. Voluntary movements are intact, though defective. Second, usually, reflexes are normal, except that sometimes, pendular knee jerk is elicited. Third, no sensory deficit. Fourth, hypotonia is a usual feature. Fifth, ataxia. Motor deficit in cerebellar disorder manifests mainly in the form of ataxia, which is defined as a defect in coordination due to errors in the rate, range, force, and direction of movement. If only cerebellar cortex is involved in the disease process, ataxia is temporary. But, if the lesion involves deep cerebellar nuclei, the ataxia almost becomes permanent. Ataxia manifests in the following forms. First, drunken gait, unsteady and wide base gait. Second, scanning speech. Ataxia involving muscles of speech manifests in the form of scanning speech. Patient scans the syllables while speaking. Third, dysmetria, when patient attempts to touch an object, usually the hand overshoots instead of reaching the target. This is called dysmetria, inability to measure the length or distance. This is also called past pointing. Fourth, rebound phenomenon. This results due to inability to put on brake, suddenly stop, of the ongoing movement. For example, if the patient is asked to flex his limb against resistance and then asked to stop immediately by withdrawing the resistance, he cannot stop. Rather, his arm moves with a wide arc. This is called rebound phenomenon. Fifth, adiadochokinesia. Inability to perform alternate movements rapidly is called adiadochokinesia. For example, patient cannot perform supination and pronation rapidly. Sixth, decomposition of movement. Inability to perform movement that involves more than one joint simultaneously. Therefore, cerebellar patient dissects such complex movement and performs movement at each joint slowly and separately. Thank you very much.